Assalamualaikum and very good morning to one and all. So I'm Afiq, the Paediatric Radiology Fellow from Hospital Tunku Azizah. So today I'm going to share with you regarding pediatric radiography. Right, pediatric radiography is quite a vast topic. I need to cover pediatric radiograph from head to toe, and then I think it's quite a lot and it's a bit difficult to cover within 1 hour. But I'm just going to highlight or touch on the important thing, particularly that make a significant thing in the setting of emergency department. All right. First of all, we are going to go a little bit on the consideration in pediatric imaging, and then we go through all the system, and then before we end, there will be a little bit of a take-home message. All right, consideration in pediatric imaging. All right, pediatric patient, they are variable in size. And then as they grow older, their physiology, they have changes in their physiology. And then the skeleton itself, it demonstrates marked changes throughout the years, right? And then as there is a maturation of the apophyses and epiphyses, and then there's a progressive ossification of structures. So this is basically in other words, pediatric radiography is quite different from the adult imaging. All right. When we conclude, trying to conclude the diagnosis based on the radiograph, we need to bear in mind it should be age-related. The thing which is common in infant will be common in infant and less common in the childhood, in the older children, sorry. And then as we know, the disease that affect children are vastly different from the adult. And then lastly, quality and patient safety. There's no higher priority exists than patient safety, right? And then as we know that pediatric patient, some of their organs and structures are much more radio sensitive as compared to adult, right? And then as we know that they still have many more years to live. So any mutation or changes which is effect of radiation will be might portray in their adulthood. So it is important to adhere on closely on to the ALARA, which is as low as reasonably achievable. Right, so we don't do all the unnecessary images, be in pediatric or adult. Okay. All right. So first of all, we are going to go through a little bit on the airway. First is acute upper airway obstruction, by which acute stridor is the most common indication in pediatric airway, and the cause could be inflammatory, like in croup, epiglottitis, tracheitis, or retropharyngeal cellulitis and abscess, and probably there will be a foreign body in between, right? So this is a frontal radiograph of the neck. As you can see, this is the trachea. If you can see my cursor here, right? It is expected to see some narrowing at the midpoint of the trachea or the upper part of the airway. So this is the glottic area. All right. So what most important thing is the subglottic area. It should be very spacious like this, and then it will portray as a shouldering here. So this is basically a normal radiograph of a frontal neck X-ray. All right, so this is another case where this kid presented with acute stridor. As you can see, this appearance is a bit different from the normal radiograph. We can see that there is a narrowing here, which is expected at the glottic region. But as I mentioned earlier, we should pay more attention at the subglottic area, which is the much more inferior from the glottic region. So in this radiograph, we can see that this space is a bit narrowed, right? And then the lateral border is quite smooth out. These are okay. And then if we do the lateral radiograph, we are lucky you can see some narrowing of the airway here. So this is basically croup, by which this radiograph portray a steeple sign, right? So steeple sign, so this is what steeple look like, as you see the bumbung of the church, by which there will be quite pointy upwards, right? So croup is actually best seen on frontal radiograph. If you are lucky, you can see some narrowing on the lateral radiograph. So the key point is loss of normal shoulder, which is the lateral convexities at this subglottic region, right? This is because of the subglottic edema. Right, so this is another case with a child presented with acute stridor. So this is what we call a thumb sign. This is the epiglottitis, which appears markedly thickened, right? So epiglottitis is another condition which is life-threatening. It is caused by Haemophilus influenza, and then the patient will present with very toxic appearing with abrupt onset of stridor, dysphagia, and fever. All right, so this is another case, probably a little bit older kid with acute stridor. So we do a lateral radiograph. So what obvious here is that the prevertebral soft tissue is markedly thickened, right? As shown in the region labeled A, right? So if we see this thickened prevertebral soft tissue, we should scrutinize it further, whether we can see any calcification, any lucency within to suggest gas, right? Like in this case, we have the privilege of CT scan, by which it shows rim enhancing collection at the retropharyngeal region. So this is basically a retropharyngeal abscess. Right, so we move on to the lower airway obstruction. So if a patient have a lower airway obstruction, the most common cause will be presentation will be wheezing, and the cause could be either intrinsic or extrinsic. Intrinsic will be bronchial foreign body, tracheomalacia, or any masses. If there's extrinsic compression, patient might have some vascular rings. All right, so the role of radiograph in lower airway obstruction is basically to exclude other acute causes of upper airway obstruction, and then to evaluate for other processes that can cause wheezing, such as the cardiac disease. Right, so this is a kid with presented with wheezing. He had no other medical illness before. The kid is around probably 3 years of age. So what obvious here is that there is asymmetry of the lung volume, by which the left lung volume is much have a higher volume as compared to the right, and then the left lung volume is more radiolucent as compared to the right. So in this case, basically the physician suspect if there's any foreign body ingestion. If we scrutinize the airway, we can't see any radio-opaque foreign body along the trachea as well as the bronchus. So in this case, there's uncertainty, and then they proceed with further imaging, which is first one, the right side down. So this basically still a frontal radiograph, but they put the patient in decubitus position with the right side down, by which it shows persistent hyperinflation or attrapping of the left lung. And then they do another one with the left side down, which shows similar thing, by which the left lung is persistently hyperinflated. There's no change in the lung volume on the left lung. So this is basically highly suspicious of a foreign body. Right, foreign body, dislodgement of the foreign body most commonly seen in the bronchus. So the features will be asymmetric lung aeration, by which there will be unchanged lung volume, just like we saw in the previous case. And there will be hyperinflation. The affected lung will be oligemic, and in worst case, there will be pneumothorax and pneumomediastinum. And rarely we can get patient presented with atelectasis or lung consolidation. So this is because this foreign body that dislodge within the bronchus act as a bulbar effect. So instead of causing the lung to be collapsed, it's basically cause the lung to be persistently hyperinflated or air trapping, right? One third of the inspiratory film can be normal, and the key radiographic features is again unchanged in lung volume. All right, so this is another case, a kid with suspected coin injection. So these are two different kids. So the first one, we can see that the coin is basically located at the upper airway and it is end on. Right. On the second case, the coin lies a little bit more vertically and it's not end on. Right. So based on this radiograph, can we basically localize where the coin is located? It's either in the trachea or in the bronchus. Sorry, in the trachea or in the esophagus. All right. So the point is, regarding this case, is that to scrutinize the position of the coin, as we know that the trachea or the airway, they have a cartilaginous ring, and this cartilaginous ring is a C-shaped ring, incomplete ring. Okay, so if there's a coin dislodged within the trachea, it is impossible for the coin to be located and on like this, right? So it will be vertical, like this, like the case on your right. So it is safe to postulate that the patient on your right, we have the coin is located within the trachea, and the patient on the left, the coin is located within the esophagus. Right. There is basically no need to do a lateral radiograph, because from the frontal radiograph we can already postulate where the location of the coin is, and then we can always direct the surgeon or ENT, the surgeon to on which part of the structures they should scope first, right? But in this case, on the first patient, we have a privilege of a lateral radiograph, so you can see the coin portray almost posteriorly, almost at the level of the vertebral spine. So basically saying that this is located much more posteriorly, so it's within the esophagus. All right, so we move on to the next chapter, which is the chest. Thymus has always been a nemesis for the radiology MO, radiologists, as well as the EDMO. When we do chest X-ray on the younger children, we know whether this is basically a normal thymus or this is a mass within the mediastinum. So as we know that normal thymus can have a variable appearance, and it can be seen large, it can be enlarged in the children less than 5 years of age until it start to involute. And then again, it has variable configuration. The most famous one is the Sale sign, by which it portrays as a triangular extension of the thymus, which is most commonly seen on the right. And the thymus structure is very pliable, by which it's very soft. You will move with heart beating pun dia akan move. So there is almost impossible for a normal thymus to cause any mass effect. Okay. To make things worse, there's a condition which is thymic hyperplasia or rebound, which are seen in post-infection or post-chemotherapy. So this will cause further dilemma for us to say whether is there any mediastinal mass or is it a normal thymus. So again, this is the appearance of a normal thymus on radiograph. On your extreme left, it's a triangular appearance. So the giveaway point is basically, I want to see that the shape is triangular. That's one. Number two, the border is very sharp. Okay, there's a very sharp inferior border, straight inferior border, and straight lateral border. Right, on your image B, the inferior border is made up by the notch or the fissure. So there will be a straight line down here. And then on image C, we can see that the thymus can be very large and it can extend until the diaphragm. But if we scrutinize further, there will be a wavy appearance of its border. So this will be another giveaway point that to say this is a normal thymus. So again, better images of showing normal thymus, very sharply demarcated, triangular shape, quite homogeneous. This is a clear sign of a normal thymus. You can see that the airway, the trachea is still patent. It's a bit rotated, but the trachea is patent. No mass effect from this opacity. Right, so this is another radiograph showing a normal thymus. We can see the very sharp border laterally, and the airway, if we scrutinize further, we can change the windowing here, we can still appreciate a normal airway. And then the lung is very well aerated. All right, so basically there are no secondary sign of any mass effect onto the airway. So just a sneak peek of a normal thymus appearance on CT. So this is the arch of aorta, so this is the thymus. As you can see, it is very homogeneous and it can be iso-dense to the adjacent muscle. Whenever you are in doubt, ultrasound is a good adjunct tool to see whether is there any mediastinal mass or is it a normal thymus. Right, so a normal thymus on ultrasound will appear as snowstorm appearance, and as I mentioned earlier, the thymus is pliable, by which it is moving with the heart movement. Right, so if there's any mass, the thymus will be more hardened, so there will be more mass effect. It won't move as much as a normal thymus, and probably we can see some calcification. All right, in a acute or in a trauma setting, sometimes patients presented with a pneumomediastinum. So this is a case of pneumomediastinum by which the air extend superiorly and it lift up a normal thymus, and this is the spinnaker sign or angel wing sign. Right, so this is another case of a trauma-related patient. Because in the trauma case, the first thing that we need to scrutinize is any abnormal lucency. And then in case of pneumothorax, sometimes we are too focused to look for any pleural line on the side. But in some pediatric cases, it will be a little bit different, by which like in this case, yes, there's a lot of pneumomediastinum, air everywhere, but you can see that there is an air locule at the left lower zone here, by which it is causing delineation of the left hemidiaphragm, because in this case, perhaps the left pneumothorax is quite small, and then when we do the radiograph, we are doing a supine position. So instead of taking the normal appearance of pneumothorax, it just sit anteriorly. So this will be the appearance of a small pneumothorax. All right, so this is a typical features of pneumothorax. This is quite a huge left pneumothorax. You can see the pleural lining here, and beyond that there will be no pulmonary vascularity. All right, so this is another case, which is also a pneumothorax, which is quite subtle. As I mentioned earlier, we can't really see any pleural line here, but there is a deep sulcus sign on the left side by which the costophrenic ankle take a deep dive here, down here, because of the small loculated pneumothorax. Okay, if you can compare on the contralateral side, is much more radiolucent here. Right, so this one is basically a small left pneumothorax. Again, another case of an ill patient. As you can see here, the chest tube already inserted. Yes, you can see some pleural line, but you can see some loculation here as well at the right upper and mid zone. So this is pneumothorax as well. All right, done with the chest. We move on to the heart or cardiac. In pediatric patient, we can safe to say that the normal cardiothoracic ratio will be up to 60% or 0.6. If it's enlarged, we should consider other causes, which are the congenital heart disease, cardiomyopathy, congestive heart disease, or pericardial effusion. Yes, we can see any typical features like a boot-shaped heart or ache on the string, but I think the most important thing is for us to pick up whether the heart is enlarged or not, and what matter most is the patient should have an echocardiogram assessment after that, because echocardiogram is much more superior than radiograph to see what is the underlying cause or any congenital heart disease or cardiac defect which there is on the heart. All right, so this is an image of a pericardial effusion. What obvious here is that the heart size is enlarged, increased cardiothoracic ratio, but we can see that the heart border is very sharp and crisp. Right, so this is basically a pericardial, highly suspicious of pericardial effusion. Why the border is very sharp in the case of pericardial effusion is because in a normal patient without any effusion, the heart is moving and beating. But in the case of pericardial effusion, yes, the heart still beating, but the pericardium stays still. Right, so there is less motion artifact. So in the end, when we do a radiograph, the pericardium, the border will be very sharp. Right, we move on to the next system, which is the abdomen. Of course, in a trauma setting, we can escape from seeing from scrutinize the abdominal radiograph to look for any free air within. All right, so this is a young baby, probably an infant with surfactant deficiency. As you can see, the altitude is inside too. The lung is not normal, right? So what we need to pick up is from this chest radiograph is the air under the diaphragm. All right, so this is quite obvious, and then there is a liver lucent sign. All right, because in a normal case, the heart opacity should be similar or the same as the liver opacity, right? But in this case, the liver opacity is much less. So this is what we call a lucent liver sign. So we should ask for a proper abdominal radiograph. And in this case, indeed, what we see is quite a massive pneumoperitoneum. There's a falciform ligament sign, and there is also a regular sign here. I think this is a case of I think jejunal atresia, perforated jejunal. All right.
Dia ada banyak ada.
All right. Again, this is another example of a loosened liver sign. At a glance, if we don't scrutinize it properly, probably we would call this as normal, but we can see that obviously the heart opacity is much more as compared to the liver. All right, so this is one of the trick or points when you want to scrutinize the abdominal radiograph. Right, whenever in doubt, you would want to take a secondary view, and then in case of pneumoperitoneum, what is suggested now is a cross-table lateral view instead of a decubitus view. Cross-table lateral view is by which patient just lie supine, and then we just take the radiograph from the side. So the advantage is we no need to move the patient, and then after we don't need to wait for like 5 minutes after reposition the patient, and then in this case it's quite sensitive to detect a small pneumoperitoneum. So like in this case, you can see there's a quite amount of air anterior to the liver, right? So these are all free air in the case of pneumoperitoneum. Right, next on the abdomen, I move on to the intestinal obstruction in children. So as we know, infant and small children, it's difficult or impossible to differentiate differentiate between the small and also large bowel. This is because there are lack of well-defined haustra and also valvular connivantes, right? So this is the appearance of a normal abdomen radiograph in an infant, right? So what we expect to see is that there will be a normal distribution of the bowel gas throughout. As I mentioned earlier, we can't really differentiate between large and small bowel, and then the appearance of the bowel take up a polygonal shape. All right. So if it's dilated, this bowel gas will appear more round, and then some after that will be more elongated. Okay, so that we should call that as a dilated bowel already. Right, the most common cause of intestinal obstruction in older children include adhesion, appendicitis, intussusception, inguinal hernia, malrotation, or Meckel's diverticulum. Right, role of imaging in appendicitis is basically to identify alternative diagnosis. We don't usually do abdominal radiograph for a case which is suspected appendicitis. And then appendicolith is seen only about 5 to 10% in patients with appendicitis. So what are the other findings that we are looking at in the case of appendicitis? So the findings are probably air fluid level at the right lower quadrant if you are lucky, and then probably some loss of psoas margin and perhaps some small bowel obstruction. So all these findings are basically quite non-specific. So these are appearance of the appendicolith, round like a stone at the right iliac fossa. Okay. All right. So these are abdominal radiograph of a case with acute appendicitis. I think this case, the appendix already perforated. As you can see that the bowel gas is not really symmetrically distributed. There's a lot of paucity of bowel gas, right? And then if we scrutinize further, perhaps we can call this as a air fluid level, but it's quite difficult and not very non-specific, right? So in doubt, perhaps patient need a quick ultrasound to look at the appendix and to look for any possible collection at the right fossa. All right, so next one is intussusception. 90% of the case are idiopathic, but the cause is thought to be related to lymphoid hypertrophy. And the findings on radiograph will be paucity of gas within the right abdomen, and perhaps there will be an absence of air-filled cecum or the ascending colon. So this is a case of intussusception. Again, we don't usually do abdomen radiograph for a case of interception. Perhaps you want to look for other cause of intestinal obstruction or whatnot. But in this case, you can see there's a paucity of bowel gas at the right upper quadrant, right? Almost round in appearance. So this is the interception. Right, so this is a quick view of interception. If you do ultrasound, we can see a target sign or pseudo kidney sign. All right, on a fluoroscopy, so this is what we expect to see. If we inflate the air will go from the distal bowel. As it reach the interception, it will appear as a claw sign like this. Right, it is still done fluoroscopy reduction of interception, but in a certain center only. For our center, what we usually do is ultrasound with hydrostatic reduction. All right, so this is another case where the kid presented with suspected to be intestinal obstruction. So we need to scrutinize everything on the abdomen radiograph. But this case is quite obvious. There is a herniation of bowel gas, herniation of the bowel into the scrotum. This is a inguinal hernia. Sometimes the inguinal hernia is quite small, so you really need to scrutinize everything, right? All right, swallowed foreign body. Majority of the foreign body able to pass through the GI tract without any complication. So if the initial X-ray demonstrates foreign body in the stomach or more distally than in the GI tract, follow-up X-ray are basically not indicated unless the child develop obstructive symptom. Right, and then the least likely area for foreign body with spontaneous pass is the proximal esophagus, which is at the thoracic inlet. If the foreign body able to pass through the proximal esophagus, so most likely they can pass through this one. Right, so this is a kid. This is quite tricky because magnet injection is quite dangerous. If the kid swallow the magnet in one go, then it will be less hassle because perhaps the magnet is sitting in the same lumen. But if the kid swallow the magnet one by one, that will pose more problem because the magnet could stick together in the abdomen, and each of these magnet might be in a different part of the bowel lumen, and that will cause more problem, by which there is higher chance of bowel erosion and also perforation. All right, so basically this another kid ingested foreign body. So as you can see that the appearance is quite lepe, right? But you can see that the edge is there's a bump edge. So this is basically a battery button. All right, so this is how we differentiate between battery button as compared to the coin. Right, so coin won't have any bump on the side. So in this case, the surgeon need to put in a scope, and this need to be removed as fast as possible because ingested battery button can cause erosion of the bowel. Right, now we move on to the another big chunk of this presentation, which is bone fracture in pediatric case. Right, I will go through the type of long bone fracture, and then we go through some of the common bone fracture in pediatric. Okay, so long bone fracture can be divided into incomplete or complete, as well as physical injury. Okay, so this case, we have a good AP and also lateral view of the radius and ulna. If we just have one view, like the AP view, it is quite misleading. I would probably call this as normal. But if we compare it with the lateral view, we can see that there is a bowing of both radius and ulnar bone. So this is basically a plastic deformation. this is a good case to show the importance of AP and lateral view. So of course, you know that these means, right? So this is why radiologists want two views, right? So lateral view is quite misleading. So we need another view to confirm the findings, right? So pediatric bone is quite tough, right? It is stronger compared to adult. So because in a normal bone, if we put in force to the bone, there will be perhaps plastic deformation. But if we put more force on the bone, there will be cortex breaking on one side. And if we give the biggest force, probably the patient will have a complete fracture. As compared to adult, the bone is much more, let's say, brittle as compared to the to pediatric patients. So we don't really see plastic deformation and also green stick fracture in an adult. Right, so this is a green stick fracture. It's basically an incomplete fracture of the long bone, and one of the cortex is intact. Okay. So this is a torus or buccal fracture. At one glance, probably we can we say this is a normal radiograph, but if we scrutinize further, we can see that there is a bump at the distal radius. So this is actually a buccal fracture of the right distal radius. Again, example of a buccal fracture on AP view, we can see there's a bump there, but we can also see some sclerosis here, and on the lateral view, we can see that one of the cortex has already the cortical break at this region. Right, so we can call this as a torus fracture or green stick fracture. Right, torus is a incomplete fracture. Probably you can you pernah tengok this type of tiang, right? So torus is basically the one yang below this. It's like a bump of the pillar. So this is what they call torus. So this is how the name arises. So this basically is because of axial loading or axial injury to the bone, which cause axial compression and break. Alright, so this is an example of different between torus and green stick. Alright, next we move on to the complete fracture. Complete fracture can either be oblique, spiral, or transverse. It is relate on how the mechanism of injury. For oblique fracture, usually because of high force, this is an unstable fracture. Spiral fracture, usually because of the rotational force being applied to the bone. And if there's a longitudinal force, the patient will have a transverse fracture. All right, another fun fact that we need to know about kids, right? Of course, we know that kids are very, very active. Perhaps they are more active than Messi and Cristiano Ronaldo combined. But rarely these kids presented with ACL injury or meniscal injury. This is because the kid have a growth plate, which is the physial. So this growth plate is basically the weakest point of the bone for the kids, right? So physial growth plate injury, kids have a higher tendency to have a growth plate injury or fracture, as it is the weakest point of the bone. All right, if you talk about physical injury, we can't run away with the Salter-Harris fracture. So Salter-Harris, as you all know, there are 5 types, SAL, TR. Right, so this is just an example. I just go through a little bit fast on this because I think we are running out of time. All right, next we move on to the common pediatric fracture. Okay, so common pediatric fracture usually involve the elbow or distal radius, clavicle, and as well as the tibia. Right, they can have other type of fracture, but they are less common as compared to these 4. As for the elbow, the most common one, of course, the famous supracondylar fracture, and second one is the lateral condyle fracture. Right, so this is a case of 2-year-old boy which fall from chair and fall from in a flexion elbow positioning. All right, so on AP view, probably it's fairly normal, but on the lateral view, we can see because there's a lot of line that we need to scrutinize on the elbow radiograph. So in this case, if you draw an anterior humeral line, anteriorly, it doesn't really transect the capitulum. So this is highly suspicious of supracondylar fracture. If you go back to the AP radiograph, we can see this lucency just above the olecranon. So this is basically a supracondylar fracture. All right. Supracondylar fracture. Supracondylar is basically the weakest part of the elbow joint. That's why it's very common. And then, of course, one of the key points that we need to see on the elbow radiograph is the fat pad sign, but visible fat pad sign without demonstration of a fracture should be regarded as an or-cut fracture. So a little bit on the fat pad. If you see the diagram here, this is a normal case. Of course, all patients will have a fat pad, but it will be abnormal if the fat pad is elevated. Right. Usually, in a normal case, it's normal to see an anterior fat pad, but if it's markedly elevated, or some people call it like the sail sign of the anterior fat pad sign, or of the anterior fat pad, we can say that this is already a fat pad sign, right? If you see a posterior fat pad, then it's always abnormal. Right, so this is what I mentioned, the anterior humeral line, it should transect the middle part of the capitulum. So this is two different radiographs from two different age. Right, so another line that we need to scrutinize is the radiocapitular line, which is the mid part of the radius should intersect the center of the capitulum. Disruption of the radiocapitular line is highly suspicious of dislocation. All right, supracondylar fracture, we cannot rhyme with the Cartland classification, which is that's grade 1, 2, and 3. Probably can read up on this. All right, so the second most common elbow fracture in children is the lateral condyle fracture. So this type of fracture is a little bit more subtle because in the kid, there's a lot of cartilage here. Sometimes only the cartilaginous part is which is involved. Sometimes we can see like a chip fracture here, but now we already know that lateral condyle fracture is one of the common type of fracture in children. Probably we want to scrutinize this region a little bit more, right? So as you know that if this fracture is left untreated, the fracture fragment can migrate and cause significant morbidity. All right, next common fracture is the distal radius fracture. If you can see my previous slide, I did show quite a number of distal radius fracture, and this commonly occur at the metaphysis. And then if it physical involvement, Soter Harris 2 is most common, and this type of fracture can be either torus fracture, density fracture, or complete fracture. Right, the third most common fracture in children is a clavicle fracture. Usually AP view is often sufficient to diagnose this. As clinically we can palpate, there will be pain or swelling. But if really in doubt, we can ask the radiographer to do a 45-degree cephalic tilt view if needed to see if there's any subtle fracture there. Right, so the fourth one is the tibia fracture. There's a condition which is called toddler's fracture, which is a minimally or undisplaced spiral fracture of the tibia. Usually occurs in a kid which is less than 2-year-old. Typical history is like the kid is baru belajar nak berjalan, and clinically patient might presented with very vague symptom and probably just refuse to weight bear. All right. So it's very, very subtle. It's just minimally or undisplaced spiral fracture of the tibia, usually occur at the mid shaft, right? But spiral fracture of the tibia is okay. You can regard this as total fracture, but a spiral fracture occur in the femur is highly suspicious of NAI. Right, so a little bit on NAI. This topic deserves a session on its own, but just a run through NAI. We should suspect if the history doesn't tally with the radiographic findings, probably there will be multiple age of fracture healing. And again, spiral deficit fracture is suspicious, and patient might have either metaphyseal fracture or rib fracture, bucket handle, and fracture of the outer end of the clavicle. Mid clavicle fracture, it's okay, it's quite common for children, but the outer end of clavicle is highly suspicious of NAI. All right, so last part before we end the session, a little bit on skull X-ray, skull fracture. I just want to highlight this condition, which is a ping pong fracture of the skull. It's basically a depressed skull fracture of infant. Is because of the inner buckling of the cavarium. Is basically a type of green stick fracture of the skull bone. And then if we do the radiograph, we can't really see the fracture line, but we can see there's a big deformity. It's like a curve of the cavarium here. So this is basically a ping pong fracture. If we do CT, we have a 3D reconstruction. This will be the appearance. So we can't really see the break in the cortex. It's just like a lopong or dent onto the skull bone. So this is one of the things that probably you want to scrutinize when you are assessing the skull radiograph. Right, so we are towards the end of the session. So some take-home message. Again, the famous quote is that pediatric are not small adult because of the reason that I mentioned that I already mentioned earlier. So we need to image gently and we need to adhere with the ALARA, which is as low as reasonably achievable. And again, there's no need for a comparison radiograph or radiograph of the non-affected side. Usually, radiograph of the affected side is sufficient. Probably if you want to compare, you want to look up, compare with other patients of a similar age. Probably that will be a better way if you want to compare. And then most of the time, we don't need a repeat radiograph. But if you really need to repeat any radiograph, it should be justified. Okay, perhaps based on the clinical condition. All right, so this is the book that I would recommend you all. I survived my first and second years of masters by reading this book. One of the book, okay, it's actually accident and emergency radiology, so it's quite comprehensible, and the way they discuss the topic, probably we can relate. All right. So with that, I thank you.
Thank you, Dr. Abi, so much. Assalamualaikum.
Salam. Bye.